through the initial foot pressure, posture, and gait testing. We know that the foot pressure of the patient is biased towards the hindfoot. Then the transverse arch of the foot collapses. Both feet land on the lateral side. The hallux valgus of both feet is severe. In combination with her posture, her entire pelvis is anterior and with lateral tilt. Under this risk, she could also have scoliosis. So let's go back to the gait report. As we mentioned just now, when her feet land and push off, her ability to extend the forefoot forward is relatively weak. That is to say, her forefoot is in a stiff and varus state. Then both calcaneus are valgus. When she walks, the state of her feet is not stable, and she has poor feet control. At the same time, her feet are asymmetrical. The right foot is in a toe out and the left foot is toe in. This is related to the patient's usual habits of crossing legs and sitting crookedly. After that, we conducted precise measurements of the angles of her feet. We got the varus angle of her forefoot, angles of calcaneus resting position and neutral position. Our treatment method is adding angles on the lateral side of forefoot. We did a 2-degree and 3-degree separately on left and right foot. It is achieved by pasting inclined patches. The purpose of doing this is to enable her toes to touch the ground more fully when standing. The second purpose is that the forefoot can exert a greater push-off ability. For the hindfoot, we increase the varus angle by 1 degree on the left. Because our semi-made insoles themselves have a 4-degree calcaneal varus angle, therefore, for this patient, only 1 degree needs to be added on the left. It's also okay not to add. For patients with severe calcaneal valgus, we need to subtract for degrees from their valgus angle and then add patches. Her midfoot arch support is acceptable, but not good enough because she bears weight on the lateral side of both feet. Especially the weight bearing for forefoot is more on the lateral. When she stepped on the insoles, we observed that the arch of her foot was still supported, not weighed down by her weight. Then we can add no midfoot accessories. If the patient's weight is too large and presses down the arch of the foot, then we may need to add 1 accessory on the arch. Finally, because the patient's transverse arch collapse is relatively obvious, we can actually add an accessory for the transverse arch as well. But since the patient is fitting the insole for the first time, it's very likely that she won't adapt to the orthotic insoles at the beginning. We can wait until the patient has worn the current insoles for 3 to 4 weeks. We'll ask her to come back and do a new assessment. Then we'll see if it's necessary to add a supporting attachment to her anterior arch at that time. This is the situation of this patient.